Welcome. My name is Barbara Brandt, and I'm Director of the National Center for Interprofessional Practice and Education. And I'm happy to introduce today's webinar on Lessons Learned from the Accelerating Initiative, a national IPE implementation study. And joining me today are two people, Carla Dieter, who has served as the Accelerating Initiative Coordinator, and Theo Lienman, who is with the Harder+Company Community Research. They conducted the external evaluation of this initiative that you'll be hearing about today. The National Center is a jointly accredited provider, and CE credits are available for this webinar series for an optional fee. None of the presenters have disclosed any conflict of interest. I want to take this opportunity to acknowledge the 4 funding foundations for the Accelerating Initiative. And as you'll hear, this is their vision for this initiative that the National Center had the good fortune to carry out. So we extend our gratitude to these funders for their vision and their support. Just a little bit about the National Center. Many people on this webinar will know about us. We were created in 2012. It was a competitive peer review process by the Health Resources and Services Administration, and the 4 foundations were a part of the original funding for the center. In the funding opportunity announcement, there were 2 principles that we stick to this day. We are committed to leadership, scholarship, and evidence to guide the nation in interprofessional education and collaborative practice. And then, importantly, we have to be an unbiased, neutral convener, which means we cannot favor one model over the other, one profession over the other. And so we work to facilitate interprofessional education in an unbiased way. And then, as you will hear in this webinar, we actively are implementing new models of care and learning ourselves. I always start every presentation with the World Health Organization definition of interprofessional education that occurs when 2 or more professions learn with, about, and from each other to enable effective collaboration and improve health outcomes. And that's the story you're going to hear today. And then the National Center's call to action is that healthcare education and healthcare delivery must be simultaneously redesigned to be better integrated and more interprofessional while demonstrating outcomes. And this is what we call the Nexus. And this is what you're going to hear about today on the initiative, and then in the future webinars, individual stories about implementation of the Nexus. So the topics for today, we will be describing the Accelerating Initiative, and we will have Theo talk about the external evaluation results, themes and outcomes, and then we'll introduce future webinars and how did they do it. So this is our website. Those of you who responded to join us today, we put up a website on this entire initiative. So the Accelerating Interprofessional Community-Based Education and Practice. So everything we're going to talk about is on this website so that you can freely explore, and we'll be archiving webinars as we release them on this website. So Carla?
Good afternoon, everyone. I want to welcome everyone, and we're looking forward to explaining everything that we've been doing for the last 2.5 years with the Accelerating Initiative. As Barbara explained, it did start off with a vision of 4 private foundations, and they asked the National Center to fulfill their vision. The 4 private foundations recognize that they have the importance of interprofessional education and collaboration, and the importance of the 2010 Future of Nursing report, which outlined major recommendations for the role of nurses in the development and leadership of emerging collaborative care models. So through this partnership, with the National Center. We had a national call for proposals, and 16 out of 46 nursing schools were selected. Most were led by advanced practice nurse leaders and in teams of true community settings. The 16 sites were part of a 2-year cohort, and the unique part of that is that the grant included a significant amount of technical assistance provided to the sites over those 2 years. Each site received $50,000, and another unique part was that there was a requirement of a $50,000 match. And many of the sites received a match from their community partners. So that really showed the community partner commitment. Part of the grant requirements also included working with the external evaluator, which was Harder+Company. These are our accelerating initiative sites. This is our whole 16 cohorts. And these sites are really showing that everybody benefits from this new education community partnership model. The students, the people needing the care, the families, the care providers, community leaders and agencies, the universities, the healthcare systems. We had a wide variety of sites and a wide variety of programs that they were implementing. And there were some fantastic impacts and outcomes that we were seeing through this 2.5 years. I can only give a few examples, but I want to highlight a couple. For example, Creighton in Maryland are showing that improvement of diabetic health indicators like hemoglobin A1Cs in high-risk complex patients. They're also showing that increased patient satisfaction. Washburn in Arizona have increased access to care, and they've opened new clinics. They've expanded care. They've developed sustainable business models, including third-party billing. Colorado and Oregon enhanced services for older adults by identifying unmet needs during home visits, and they were actually expanding the reach of primary care providers. Utah and Rochester are expanding their partnerships into the community and integrating their services into health systems. Nebraska and New York are incorporating education to the current workforce while also educating students. Pittsburgh and Hawaii leverage strong community partnerships to enhance access to care. And all of this while improving the collaboration skills for students in authentic clinical environments.
Why is this initiative important? So we believe this is an essential paradigm shift, redesigning education and practice together. And what we learned through this initiative is the true importance of starting with patients, people first, and populations, and then design what we're going to teach or what the students need to learn in authentic practices around what the patients need first. This demonstrated, this initiative, the effectiveness of advanced practice nurse-led teams. And then the models had broad engagements of students as valued team members. And in this redesign, the health of people, patients, and families can be positively impacted by the redesign. Interprofessional community-based care, creating potential for cost reductions. And several of our sites did so. They're actually able to demonstrate the value added of the model to cost reduction. And also the sites are learning, many of the sites, how to sustain their programs beyond the grant funding.
So another unique part of this grant, we started off this grant and the sites and their teams came for a 3-day team-based kickoff institute. So both the academic and the community partners came to the institute for 3 days. They went through some intensive coaching and time together. That we had ongoing engagement in a virtual national learning community, and affinity groups were organized around populations serving geriatric mental health, substance abuse, and primary care. And we applied the Nexus learning system, something that the National Center had developed, and the associated tools for program development, team and site assessment, and reflection and evaluation. So we had also had one-on-one demand support and coaching from the National Center experts via phone, email. As the sites developed, we considered important decisions and as they were facing challenges. We also had formal monthly office hours. We had in-person team site visits to all 16 sites. We met with faculty, community partners, and senior leadership. And next slide. So what we were doing during this whole time is we were testing 11 tools in the Accelerating Initiative. And the National Center has always provided coaching since 2012, since their inception, mostly with individual sites, and we called it a popcorn type of approach. The Accelerating Initiative provided the opportunity to implement a very standardized approach across 16 sites using these tools. And the tools, as I mentioned before, were used for not only program development, but team and site assessment. They were also used for reflection, and we also used them in the evaluation. And you'll learn a little bit more about the tools and how the tools assisted each site in developing and implementing the Nexus. And each upcoming webinar is going to highlight, each of the sites is going to chose one of the tools that was particularly helpful for their site, and they're going to discuss how that tool helped them. Couple of examples of the tools. One is the Stairstep model. What is the team's Nexus developmental stage? So this National Center model has been used for over a decade. Barbara has used it with numerous organizations and teams working together in practice and education. And today, we use it as a conceptual model to achieve the Nexus. And that model is based upon experience and observations, and the developmental stages or the tasks that teams address as their interprofessional collaboration becomes increasingly mature and sophisticated, and they build their trusting relationships. So even though it is a stair step, the stages are not linear, and in fact, the teams are often working on several at the same time. So the model is used as a framework for teams to make sense out of the complexity of IPE implementation. When we first started this, the teams reflected on where they were when they came to that 3-day institute. And I think 16 out of the 17 sites told us that they were at just the getting to know each other stage. And so even within a few months, they were moving, or a lot of their efforts were moving more towards teamwork. And as they moved throughout the program, we evaluated them on this every 6 months, and Theo will be talking a little bit more about this. The Institute of Medicine Interprofessional Learning Continuum model. Barbara, do you want to discuss that?
So this was a study committee of the Institute of Medicine, now the National Academy of Medicine. This was a model that was put forth for how to bring IPE into practice, but importantly, how to affect both learning outcomes simultaneously with health and systems outcomes. So one of the sites, Creighton, will be discussing how they use this model. I'm going to, before I turn this over to Theo, say just a little bit about the site visit. So all of these 16 sites received a team visit from the National Center, and other collaborators attended these site visits. So we have a template for what a site visit should look like, but we customized it to each of the sites. So during these visits, they actually used the tools, the ones that were meaningful for the individual sites. So we had coaching sessions during the site visit. But the point that I wanted to point out is that our research at the National Center demonstrates the importance of senior leaders, both in the community and in academic institutions, to support IPE efforts. So we worked with each of the site principal investigators to invite their deans and their senior leaders at their institutions, and they came. And that's the good story. So again, we'll be speaking more about this in our future webinars. So I'm going to turn this over to Theo so he can discuss the findings of the Harder+Company evaluation of this initiative. Theo?
Thank you very much. As Barbara said at the start of the call, my name's Theo Lienman, and I'm a research consultant at Harder+Company Community Research, and we were the external evaluator for this initiative. And I just want to start by saying it's a real honor to be on the call today because it's a privilege to share back findings. I know we worked hard over 2.5 years to put this all together, and you don't always have the opportunity to have implications shared with the community to advance future work. So that's the context I'm excited about in delivering these results. So the primary goals of our evaluation were threefold. We wanted to track outcomes and achievements of Nexus implementation, but importantly, we also wanted to identify the context that would lead to success and challenging situations for these sites. So not only what outcomes were they reaching, but what were the situations that led to those outcomes and what can we learn from those situations? And one of the things that we had to do to accomplish this work was to think about how these implications would inform work in the field of public health education more broadly. So we always had to focus on what are the contexts that are something that might be attributed to another situation that we'd want to pay forward if we do another initiative that someone can learn from this work. And the other thing that we had to do was work very closely with the National Center. So in the commitment section of this slide, what we're really trying to capture is the depth and duration of this work, working closely so that we understood the context of the sites as we were evaluating. Next slide. Now, there were several components to this evaluation, and we've already spoken about some of the data collection tools. So one of the things that we did was collect data every 6 months through site progress reports, individual team surveys, and other Nexus tools that Carla had just discussed. And we also conducted 7 deep dives with selected sites. For these sites, we had 8 to 12 interviews with members of the Nexus team, both on the academic side and the community side, so that we could put together case profiles. And those case profiles did exactly what I just discussed earlier in terms of the goals of the evaluation, which was to highlight how specific contexts of the work were leading to the outcomes we observed, both in learning and health outcomes. Now, for all of the 16 sites, we did in-depth PI interviews to get a rich understanding of their situation on the ground. And we also reviewed the documents from the National Center, like site visit reports, as we went. Now, our thinking evolved of moving healthcare into communities. And through the engagement with the National Center, one of the main findings that I'll talk about in a bit was the importance of having that community focus from the get-go. And we wanted to also notice that learning outcomes for students would emerge even though learning was not the primary outcome of the site. It's always the focus on addressing a community need, but learning grows from that focus. Next slide. Now, the results of our evaluation are highlighted in a series of documents which are available on the Accelerating Initiatives website. So you can go to nexusipe.org/advancing/accelerating to see these published documents. So on the left, we have the final evaluation report, and on the right, the series of 7 case studies that I mentioned. Next slide. Now, moving into some of the findings from the initiative, we saw that we were able to increase access to primary care, particularly for vulnerable populations. Each of the 16 sites worked with a vulnerable population. That was one of the criteria that were used to select sites to implement this work. And secondary, after improving access, in some sites, we did see early signs of improved quality care as well. Carla mentioned the example of Creighton University and improved hemoglobin A1C counts. Other sites were beginning to implement the metrics for measuring those improved health outcomes. But before reaching that barrier, you have to improve access and also increase patient satisfaction. Now, the third outcome on this slide is that students themselves had improved learning through this experience. And what I want to emphasize on the next slide is that it wasn't just about student learning, but learning in an interprofessional context, which allowed them to demonstrate their expertise and added value to the teams. Next slide. So in these interprofessional contexts, students didn't just have a richer understanding of the social determinants of health and how they were affecting vulnerable populations, but they had an understanding of how their particular discipline could work and fit into an interprofessional team so that they could emerge as a temporary leader in a spontaneous leadership model to address the needs in front of them in a care situation. So students had a richer understanding of how to effectively collaborate through these teams. And many patients, as a result of this more collaborative approach that allowed students from different professions to take the lead when it was their turn to demonstrate expertise, patients signaled that they had higher satisfaction with this approach. They felt heard and they felt that their needs were being addressed. Next slide. Now, in this next series of slides, you'll see at the top one of the recommendations from our findings, followed by some of the quantitative results from the tools that we described that the Nexus team members were filling out over the course of the 2 years. The first recommendation that we have is that Nexus sites should focus primarily on the impacting of health for people, patients, clients, families, and communities to ensure program sustainability. Now, what this means is related to what I said earlier. The goal here is to address a community need, and in doing so, to demonstrate the strengths of interprofessional teams and therefore improve student learning as you go. So we have some of the results from the 6 characteristics team survey over the years 2016, 2017, and 2018. And what you'll see in terms of shared vision and this focus on the community first is an increase over time, a positive trend in the number of sites that were on average reporting that they had to some extent or to a great extent reach this shared understanding and were focusing on community need. Next slide. The second recommendation that I'm going to share says that interprofessional community-based practice and education initiatives should address social determinants of health from the initial design of the intervention to demonstrate each profession's added value for patient care. Now, this is an important finding. The idea here is that it's not sufficient to go into a clinical context, a context of community care, and observe how social determinants are affecting health. You have to do your research on the ground, get to know your community partner, and think about the social determinants of health at play so that you're assembling the right interprofessional teams to address those needs. Otherwise, you risk putting patients in a situation where you're conjuring up many of the traumatic events from their personal social context that are leading to health needs without a solution in mind to address that need. So the most successful programs had a design in place that knew the social determinants of health at play and how to implement a Nexus team to address that social determinant of health. I'm going to read the quotation at the bottom of this slide because I think it richly captures the social determinants health piece of this work. Instead of having a patient at the counter and saying, "Do you have any questions about your meds?" It's much more relevant conversation about medications and med management within the context of their home, which I think is just phenomenal. So the focus here for this University of Colorado Nexus team is a shift in thinking about the social context as they affect adherence rather than what's the right medication to prescribe for the specific medical ailment. One final thing to highlight related to this social determinants of health piece is that you do see that improvement in health outcomes follow a predictable pattern. So you see that access to care was reported to a significant or moderate extent met by 80% of the sites. A slightly lower amount reported steps towards improving quality. And then finally, after that, is reduced costs. So this was the typical trajectory. And of course, we want to bring all sites to a place where they're reducing cost, improving access, and quality. But we'll talk a bit more about the sustainability of these initiatives and what factors can contribute to that cost reduction. Next slide. Community-based IPE initiatives would benefit from being designed around multi-site comparisons with a unifying framework to support the identification of emerging phenomena. So this relates to what Carla was saying earlier about how previously some of the work around interprofessional education could be described as a popcorn model, where things are popping up and you have different strategies or approaches, different tools being implemented, but not a good framework for thinking about doing things in a standard way, and not enough sites to do comparisons about what is working and what's not. If you see a situation where patient health isn't improving, you don't know if it's just a coincidence, some particular quirk of a program, but if you see it occur in a systematic way related to certain contexts, you can start to infer that maybe it's something about those contexts that's affecting patient health. So in the institutional commitment finding of this graphic on the right, you see that there was a higher degree of sites that were reporting a large commitment from school administration and university administration, and also a high degree reporting this for community organizations partnership, but lower than for the academics. So since only some of the sites didn't reach this metric on community partnerships, we might inquire, what were the specific contexts there? Why was it that they didn't have the same degree of community buy-in? The comparison illuminates a situation where you'd want to dive deeper into the context to learn about the barriers to full community partner backing. And another thing to share related to the multi-sites comparisons is that it allowed for real-time learning between the sites. The affinity groups, TA calls with the National Center allowed the sites to learn from challenges that their peers were facing. So one principal investigator described how the affinity groups were a way to hear from peers, promote ourselves to encourage more work like this, and identify this as a movement. Next slide. Interprofessional collaborative practice care teams that implement a spontaneous leadership model can build team member confidence and improve patient care. So I mentioned earlier how students from different professions all had an opportunity to demonstrate their expertise, to step up and to speak, to have real-time learning through practice. Now, this didn't just occur on its own. Leadership was very crucial to establish a context where people from these different professional backgrounds and focuses felt safe in stepping forward, felt that they could contribute without being judged, and that they would be heard if they had a piece of wisdom to add to the situation of patient care. So leadership was very important in crafting a context in these interprofessional care teams of psychological safety, where members from each health profession felt that they could be heard and they had something to add to the team. So 3 of the indicators related to this context of psychological safety, which leads to spontaneous leadership, all showed improvement over the years 2016 through 2018 in our longitudinal study. And a team member from Creighton University summarized it by saying, I think a nexus is really about fluidity of team and about fluidity of experiences. And so people move in and out of leadership roles, in and out of teams as their experience and expertise dictates. I couldn't say it better myself. Next slide. Now this slide is just capturing some of the work that the National Center did to support sites. And I want to emphasize that this is most of the grantee-facing elements. So these are the face time and doesn't capture all of the background work that went into the 2.5 years. So the count of hours here is an underestimate. But I think what it highlights is the different categories of TA that the National Center was providing to the sites. So we see the large slice of the blue pie on the left, 49% of the time was spent in the development of the New Models Institute implemented for the sites. The next largest category was this orange-red, burnt umber, you might say, color on the right, which is the National Center staff site visits, which was 32% of their time. And then the next two largest slices of technical assistance related to teleconferences at 6%, and the PICOT question support also at 6%. And again, a principal investigator highlighted the importance of this multiple rounds of contact through technical assistance by saying it's beneficial to hook up with the thought leaders in the field and to be able to take advantage of the work they're doing. So not just learning from peers, but people who have had a bird's eye view to be able to draw those connections between the experiences of the sites. Next slide. Now this final slide highlights some of the themes that we go into much more detail in the annual report, or the final report rather, and I really encourage you all to download that from the website and read through, because I was only able to share quotations from a few of the sites, and all of them are doing such path paving work in such varied contexts with different vulnerable populations that I really don't want anyone to feel like their initiative didn't get enough play. So please read that report. And I'm going to just highlight a few of these themes that I didn't have a chance to cover through the data. So the second bullet point here says that culture and policy change is more pronounced within the academic institution. What we observed over the course of this evaluation was that many of the community partners, people operating in contexts of practice care, already know the importance of interprofessional care teams, already see the added benefits of bringing together different perspectives. But because of the structure of medical education, of health education, we see a lot of siloed learning. And so academic institutions really benefited from being able to break down those silos and think of unique curricula and class structures that were able to bring students into these community contexts. And so we saw a shift in the academic cultures on the side of the universities to really bring them up to speed with where community partners had been all along. And another finding that I want to highlight that I didn't have the opportunity to go through with the data is the idea that sustainability continues to be a challenge for these sites. So we can highlight a lot of very promising early signs of increased access and improved quality care. But where the rubber hits the road is really, are we going to be able to develop models that are cost effective and that continue to pay for themselves through this improved treatment? Now, there's some promising things about the being able to bill to third parties, as we've seen in Washburn and Arizona, communities paying in the other $50,000 to match this initiative, and wanting interprofessional teams to continue after the accelerating initiative concluded. So we have some signs that sustainability is around the corner, but I'd love to hear people's thoughts about what the ingredients are to make these effective initiatives rewarded in a public health health system that often bills for the amount of time that patients spend in the clinic rather than the efficacy of that treatment. So I'd love to have a conversation about sustainability related to the findings that we've highlighted today. Thank you.
So thank you, Theo. I'm going to talk a little bit about so what's next. And so as you can tell, this was a whirlwind initiative. Many of the tools that you saw that Carla talked about in the list, we've worked with those for a number of years in isolation. What this project, what this initiative allowed us to do is bring these tools together and to work with 16 different sites and then to collect data on those sites. So we learned a lot, and we are learning a lot about implementation of the Nexus, using these tools, and then how to collect the data. So we will be kicking off, starting October the 31st, with a year-long webinar series, and we will be featuring each of these sites. We'll actually be doing other showcasing in other ways. And we've asked each of the sites to describe and discuss what had to change in order for them to be successful. How are they doing things differently today? And what matters most and what makes a difference to their patient population? And how did the National Center tools support the Nexus team's success? So one of the tools that's freely available on the Nexus IPE site is the Kennedy Model of Sustainability. There's a webinar that Terry Kennedy, who is the Director of Interprofessional Education at Kansas University Medical Center, presented the webinar. We actually did that tool at each of the site visits. And so that is freely available. And Theo, what's interesting is we haven't actually talked for a few months. Several of these sites have actually garnered more resources. Some are from the state Medicaid programs because they were able to demonstrate patient outcomes. I won't tell you which one, but it is one of the sites that'll be showcased in the webinar. Others, the academic health centers, have invested in the programs. In one case, one of the programs is scaling academic health center-wide. So this is sort of a showcasing of what will be a conversation in these webinars. So this is the schedule of webinars throughout the end of the year. So as I mentioned, the University of Nebraska Medical Center will be talking about an implementation in a skilled nursing facility in which that team trained everyone in the facility. That's one of the case studies of the 7 case studies. They'll be showcasing the compelling vision tool and talking about the critical success factors we've learned about implementation. On November the 6th, the University of Utah will talk about their implementation and partnership with the Housing Authority of the County of Salt Lake, Grace Mary Manor, and the Bud Bailey apartment community. They will talk about how to build an effective IPE, Nexus IPE team from the start. This is a site that has used student hotspotting from the Camden Coalition model. And they have a tremendous story to tell about scaling their model in their institution. On December the 10th, we will hear from Oregon Health and Sciences University team, and they implemented their program at Klamath Falls Health Partnership and the Cascade East Family Medicine. They will talk about the ACE-15, the Assessing Collaborative Environments, a tool that's freely available on the Nexus IPE site that they developed. And we are very pleased and privileged that they're allowing us to use their tool freely. So these are what's coming up in the end of the year, and then we'll be announcing the 2020 webinars in the near future. But we will tell you when we put new information on the sites and really encourage you to keep coming back and to learn with us as we're learning more about Nexus implementation. So with that, I am going to close the webinar, the formal presentation. As Sean Diego told you at the beginning of the webinar, please feel free to ask any questions, put in our chat box, and we'll be very happy to answer any questions that you have about the initiative, about the findings, and about what's coming up next. Thank you very much. So are there any questions or clarifications for us that we can answer right now? Anyone?
I see some questions now, Barbara.
Okay. I'm working on 2 computers right now. Somebody has asked the question about making the toolkit available. So we will be releasing a starter kit later in the year on the toolkit. based upon what was used in the sites. And then we are actually working on, we have another grant to work on modules and other education to do a deeper dive. So right now we're finalizing a toolkit that we will be releasing. So good question. Oh, thank you to whoever said this. This is extremely exciting work. Can you tell us of your recommendations when thinking and starting a new project in the Nexus? This is a really good question, and it's definitely related to the toolkit concept. This is a significant change in a mental model, and it's giving somebody tools and saying, here, go do it, will work from some sites, but it will be a challenge for the other. I think one of the biggest challenges or biggest support that Carla and I gave in this project and working in the Nexus is the concept of starting with patients and families first. And this is not just, oh, we honor patients and families. This is really significant about the redesign in practice. So as you will see, and I'm writing like a fiend right now, that concept was like gobsmacked for us. And it sounds crazy, but really getting sites to think about what is a specific focus in the clinic, in the community, and how do we design backwards. So I would say the first step for people listening is to really take a look at your partnership and what does the very specific needs of the clients, people in that partnership. And again, that's part of the story that you will hear. So that is definitely step one. Next, I would say you will hear on October the 30th, from Nebraska, the Nebraska team. They're going to take you through a compelling vision. And I'll stop in a minute, Carla, and you can pick up. But when we first started this, you can Google compelling vision everywhere. And I really didn't think that was something we needed to spend time on. But as we went farther and farther into this initiative, we realized that having these disparate groups come together and to formulate a compelling vision was absolutely critical. And it needed to be focused on the patients first. And next step is you have to be able to have an elevator speech where you can actually say your compelling vision very crisply and cleanly. So, and then we did, during the site visits, practice this compelling vision. And I'm going to give one more what's next or what you should be thinking about in this redesign is Theo showed you on one of the slides a shared understanding. So you can go out and read about the change literature about having a shared vision, so that compelling vision. But what happens is you need the time to develop the relationship so that you come to a true shared understanding of the work between education and practice. That we all learned, deans, department chairs, and even faculty themselves in academic institutions really underestimated the amount of time that would take. So to the person who asked me this question, start focusing on patients, families, and communities first in the redesign. Number two is work with your team on a compelling vision. And from that vision will come a shared understanding because you put in the relationship building. Carla, I don't know if you have anything to add. We actually are getting a lot of questions now.
As you're just looking over the next questions, I'm just going to add that we just cannot emphasize enough that starting with the patient, people, patients, families, community first. In our the sites that really partnered with their community, and we were on site visits where their community partner talked about nobody has ever come to us and asked us what we needed. many university programs have come to us and asked for, can our students come to your site? And because they need to learn about X, Y, or Z. Instead, this is a change in the model, and this is really asking what is it that you need, and then designing your program around what those needs are. And in many of the sites, patients were involved in giving input. So there's lots of things to consider, but Barbara used the term academic tourism, that we're moving away from that. That's just placing students there. And this is really where students are adding value because they're meeting the needs of the community and the people in that community.
So Theo, I don't know if you have anything else to add on what we're kind of boots on the ground. That was a boots on the ground question, so jump in if you have any observations.
And I think it relates, I see a couple questions here that relate to the evaluation component of this. So I think I'll tackle some of those if that's all right. So I see questions about wanting to hear a little bit more about the spontaneous leadership. Now this was something that emerged very organically from the key informant interviews that we conducted, because we were hearing time and again examples about the shared leadership of these interprofessional teams. And we actually circulated a few different ways to describe this, because there are similar terminologies that exist in some of the literature in the field. So you might have encountered terms like situational leadership or distributed leadership. And we thought that the term spontaneous actually captures what's going on most adequately. So the term situational leadership leads you to the understanding that if you have a certain context in place, then the correct health profession will organically step up and emerge as leader in that moment, which isn't necessarily the case. You need to have that psychological safety so that students from different health professions feel that their expertise is valued. So the situation isn't just about the patient you're treating and what their needs are, but it's also about the context of the team. And distributed leadership similarly makes it sound like there's sort of a turn-based leadership model for the health professions, that everyone will get their turn. But it's really the spontaneity that's afforded by that context of psychological safety that allows the right expertise to be a voice at the table at any given moment. So I can recall an example where people would describe a team huddle, and then a social work student would say, well, actually, I know a lot about some of the services that this patient is already tapped into. And I don't think that you were aware that they were working with this agency. And so being able to shed light on that deeper understanding of the patient's social determinants of health, because a social worker has that focus that allowed a deeper understanding of just what's going on in the clinical context. And another question that came up related to the evaluation, related to the boots on the ground that we were discussing, was the role of the community in reporting some of these findings, and in particular whether patients had a voice at the table. So there's a few different ways that patients' information made it into the evaluation. So one of the primary ways was, whenever possible, the National Center asked if the community partners could provide data, right? So not anything that's personally identifying, but the averages of the medical metrics that they already have on file. Could that be shared so that we can actually see real-time indicators of improved quality of care? But the primary way that we heard about patients' responses was actually secondhand, by having the members of the Nexus teams refer to us different anecdotes they've heard about patient satisfaction and about their particular experiences with professional care teams. Barbara and Carla, I don't know if you want to add anything about the patient piece of this.
That was, so there are a series of questions that we've received about are the patients going to get these findings? Are there patient advocates involved? And I would say that the sites, there are varying levels of patient engagement in the sites. One is an FQHC, so there's a natural board that's involved and been involved, the Housing Authority, but was really clear, and one of the sites was an addiction treatment center in which after implementation of this program, 100% completion, and they turn around and rehire the completers of their program to become staff. So there's varying levels, at least as we checked, of patient advocacy and engagement, but I have to say that this finding was so strong that we actually brought this back into how we help people develop their Nexus teams from the beginning. So we actually put a component in as to how to engage patient advocates in your sites, and this needs to be a critical success factor because of this finding was definitely so strong. You know, this is the first release of this. We encourage all of you, and certainly our 16 sites, to really go to their patient populations now and have these conversations. A really good question from one of my mentors came in, and that was, this was a nurse-led team model. And we in the National Center are an unbiased, neutral convener. This was a project that came to us that we have been testing tools that we've been using across many different implementations. And we actually have other projects going on in the center working with physicians organizations. And okay, sorry about that. So this model, we're actually starting to talk to health systems about translating the model into health systems care, physician-led teams. We think it's generic enough that it would work no matter what the environment. It just so happened that this was a gift to the National Center to be able to isolate the phenomenon, to start understanding what works for student learning and what works for patient outcomes. Other questions? I think we've answered many of the questions. If anybody else has any other questions or comments. I have to tell you, we have a computer that's dying with the questions on it, so if anybody else has any other questions or any other comments that Carla or Theo would like to share.
So Barbara, a question came in about the finding on the focus on people, patients, families, and communities first. Would you like to speak to that? I feel like either of us could take that one.
So, how do I explain this? We in academics, we in educational institutions over the past, certainly 10 years and beyond, have been very, very focused on competencies, on designing curriculum for our students, and getting them ready for practice. We found that several of the sites kept, getting people to think that that's not the only thing we're trying to do, is to affect student learning, and that as a result of that learning, something good is going to happen. And what we learned and worked with many sites on is how do you do that design of a program around a patient population? And the other thing I might comment on, this lengthy term of people, patients, clients, and families, when you work in different community settings, clinics and community-based settings, how you refer to the client or the people is very delicate. So we, in the evaluation report, introduced all of the terms and then did use people or patients as the term. But again, what I'm trying to get across is that we did observe that, particularly for academic programs, we've been so focused on making certain our students have competencies that we found it was very, very important, and the sites that were the most successful in demonstrating outcomes did start with that design first, focused on the very specific need of their patient population. Other questions?
I might just add that those sites were still, the students were still meeting their competencies. So it wasn't at the risk of the students not getting what they needed. With that focus, everybody met their goals, and that was very eye-opening for many, that we can still meet the goals that we have for our student learning, and even our staff, our current workforce, they're learning. And while we're doing this, and this is putting students in authentic clinical experiences, and where they are coming and adding value, and really contributing to the care of the people in that community, and not just being an observer or something extra tagging along with a preceptor. It's entirely.
The other thing I would say, and sort of like reflecting back, all of these sites in the RFP and the funding opportunity announcement were required to implement the IPEC competencies. We did not teach the IPEC competencies. Every one of them did a fine job of implementing the IPEC competencies. They have prepared themselves for that. They looked at other models, or they had already been doing with that. That was not an issue. The other thing I would like to comment on with the physicians, and this is a nurse-led model. Our funders, we talked to them every 90 days and kept them up to date on what we were doing. One of the observations they had in the first year is, where are the physicians? Why aren't these teams engaging physicians? And indeed, at the beginning, there were few medical students, physicians, and the like. As a matter of fact, one of the most common dyads was pharmacy and nurse practitioners. But by the end of this project, with that conversation, the number of medical students, the number of physicians involved exponentially increased. So again, the focus was primarily at the beginning on nurse practitioner-led teams, advanced nurse practice team, but by the end, there was a scaling in which not just that all professions were involved, including physicians and medical students. I'm trying to read a question. It says, tying into what our call patients that work for us is calling them neighbors. I love that. Neighbors. Love it. We shy away from clients, patients, residents, and so far it's working. So here's a new term, Theo. Calling, particularly in the community, this makes all sorts of sense, neighbors. So I like that. And as this person indicates, it's a delicate conversation. Language is always a delicate conversation in this work. Thank you very much. So we have 2 minutes to go. If there's any other questions that you have in 1 minute, send them our way, but there are going to be plenty of opportunities to engage. The next webinar is on October the 30th. This particular webinar will be archived. Share it with your colleagues. And we look forward to continuing having this conversation with you. And I want to particularly thank Theo. I'm sad because this is our last official work for now. But it was a phenomenal partnership with the Harder+Company Research Organization. They challenged our thinking, and having an external evaluator in this work was just so valuable. So I'm going to close it off, and you all know where to find us on nexusipe.org. And thank you so much.
And spread the word. Sign up for the next webinars. You will be glad you did.
Thank you all for
Thank
joining.
you.
It was a great
Thank
conversation.
you.